everybody. I'm Penny Brasher, and I am the Director of the Center for Epidemiology and Evaluation. Very, very pleased that all of you are joining us today. I want to say that we are gathered today on the shared traditional, ancestral, and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh peoples. Rob and Carrie, our guests from Mississauga, live on the traditional territory of the Mississauga of the Credit First Nation, the Haudenosaunee Confederacy, and the Huron-Wendat and Wyandot nations. Yeah, I myself was born and raised on the Huron-Wendat territories. We have to do more than just acknowledge that we work and live on the lands of these peoples. And I once met Murray Sinclair and was really just in awe of him, and it's very sad that he died last week. When the Truth and Reconciliation Commission produced their report in 2015, I went to an event at UBC where they were talking about it and saying, everybody, you need to do something. And I committed to read the report, and I committed to follow the progress of the government, and I committed to reflect on where I had been brought up and also where I had lived along the way in terms of the histories of those Indigenous peoples on the lands that I had lived and worked and played. And with his death last week, I really felt that I would double down on that. And if any of you want to know how far along we are with the TRC and the 94 calls to action, there's a very good website that CBC Investigates has produced, and it has a strip chart, which as a statistician I'm very fond of. And you can just hover over a dot and you can see what the call to action was. You can see how far along it is. And you can actually hear Murray Sinclair talk about that action. So that is my personal journey of truth and reconciliation, and it continues to this day. So I'd like to begin by introducing our two speakers, Rob and Carrie. They're both from Mississauga, Ontario, and both from the Institute for Better Health at Trillium. Rob gave a talk yesterday, both of them gave a talk yesterday, and I listened to them both, and they were excellent. So I look forward to Rob's talk today, and Carrie's participation as well. Rob. Your clicker.
Well, there's the clicker. I'm just gonna stand here. So nice to meet you guys. This is just terrific. I come from a lot, and we're trying to put in action a learning health system in our hospital. And I'm going to tell you a little bit of the story about what we're doing, and maybe that can help a little bit about how you're thinking about this. And I'm joined with Carrie. Carrie is my colleague. Institute, and it's an institute that's been around now for about 10 years, and it's focused entirely on lifting the organization in its learning activities. So the whole purpose for the Institute for Better Health, the whole purpose, but for the maybe I'll just take this off. Does that make sense? Okay, that's better. The whole purpose of our research institute is to lift the learning health system capabilities for our hospital system and our community of Mississauga. And so Carrie is a research chair like me, and we have a variety of other ones, and we're going to tell you a little bit about the story. And I first have to thank you for coming. I did my initial training, and my initial academic appointment was at UBC many years ago, and I feel like I'm coming back home to Vancouver. So I know some of you here, and it's wonderful to meet many of the others. Okay, so this is the plan for the next half hour, and please interrupt me anytime and about what we'll do. First, I just want to do some level setting for people, to do a little bit of level setting around what learning health systems are. It's confusing. Sometimes people think it's motherhood and apple pie statements, but it's not. It's actually got a precise, meaningful, research-based definition. And then I'll talk a little bit about the work that we've done to make this happen at Trillium. We developed a real practical action framework to guide the work that we do in our hospital system. I'll give you a really very, very simple example of one of the many projects that are happening at Trillium to try to take this idea forward. And it's a real clinical example, I think, something that you might be doing at your hospital system as well. And then Carrie and I are going to do a little bit of work with you around a problem that you're facing and we face at the same time. And that's around issues around hospital capacity relating to lack of long-term care capacity. Make sense? Okay. So I have to start here because this is the state of affairs in Canadian healthcare, and these are the pressures that you feel every day in this hospital system. Is it's failing for Canadians. Canadians used to have a lot of pride in our healthcare system as one of the top notch in the world, and that pride is actually dissipating over time. This is the headlines that you don't have to pick up a newspaper in Canada any day to see these headlines. And they're real. Lack of primary care, workforce is overstretched, lack of long-term care facilities, waiting too long in hospital ERs. Today in our hospital, Mississauga, I just looked at the recent stats, we have 100 people getting care in hallways today. 100 people. We have a small hospital within our hospital that's just in the hallway. Is that good enough for us? Is that good enough for Canadians to get care like that? No, it's not. We'll have to do something different than that. And what is the natural thing that governments do is build more hospital beds. Is that the solution? Is that what we should be doing? Building more hospital beds to accommodate more people in our hallways? It's part of the solution, but we have to redesign care. Okay. So these are just the stats. The one that is there's two on here that I find really quite alarming, and it's the last two. One is equity. We all believe that we should equitably distribute healthcare in Canada, but if you look at all of the trends in any province, the equity gaps are not narrowing, they're widening. People at the lower ends of socioeconomic spectrum are becoming worse off than the people at the higher ends. Okay? That's around health, that's around access, that's around a whole host of things. There's a lot of reasons for that, but that's very troubling. Okay? The last is Canadians are becoming disenfranchised for our system. If you look at all of the recent surveys, our Canadians do not believe that our system is up to the task, and it will be for them there in the future. That's very disturbing because they're looking at maybe we should have private options, maybe we should move entirely different because the system is failing the way we have it right now. Okay. So I would posit to you that we can move forward, and we need to move forward rapidly to deal with those problems. But it's not just we're going to try something and it's going to be fixed. We have to try something and learn, because we know that trying these things, they're not going to be perfect. We've got to constantly reinvent and change them. So learning is an imperative in Canada. And across the world. So the learning health system definition has been around now for 18 years. And it grew up as a conceptual idea in the United States from big think tanks, the Institute of Medicine. And it's been, norming and forming over the last decade. And now it's getting some real momentum and real ideas about what this really means to move forward. We're behind in Canada on the adoption of learning health systems. Other countries are more advanced than we are. If you look at the UK, if you look at parts of the United States, they really have much more established learning health capacities and capabilities than we have in Canada. So this is one of the reasons that I'm here today, is to really gather some momentum around how we can adopt these concepts in Canada. So this is a definition that came up with a Canadian definition, because in Canada we always have to have a Canadian definition. And it was written by John Lavis at McMaster. But it's really defined as a combination, a merging of a research infrastructure with a healthcare delivery structure. They're no longer independent, they're merged. Okay. Second is it's anchored entirely on the needs, aspirations, preferences of Canadians. They are our taxpayers. We need to serve them. Okay? So we have to anchor on what they want and what they need. Okay? Second is it's rapid. It uses data and evidence rapidly to change. Okay? It's enabled in our systems by a whole bunch of enablers, and I know many of you are in this enabling function here today. Enabled by decision supports to put this into action immediately. Okay? Aligned governance arrangements. And then I think we have some hospital governors or some Vancouver Coastal Health Authority governors in the audience today. Financial and care delivery arrangements, okay, to make this happen. And then finally, it's built on a chassis of rapid improvement. And this is a new or enhanced culture and competencies in our organizations. Okay. So this is a diagram that some people find helpful to think about this relationship between research and care. Traditionally in Canada and across the world, it's always been traditional, research is done at universities or in academic institutes. They publish in journals. They expect that it's just taken up in the healthcare system over here. And we know that doesn't work. Okay, does that sound good? You'll probably be able to record it with me speaking like that. Can everybody hear me there? Okay, let's try it this way. So historically, it's been this top diagram. Research over here, healthcare delivery over here, and it's just naturally thought that it would come over here. We know that doesn't work. It's haphazard. It doesn't reach everybody. It comes in fits and starts. And in Canada and across the world in the last 30 years, we've been on this journey, what we call knowledge translation and exchange, which I view as just a brokering function, drawing the two closer together with brokers on each end to make sure questions are asked in the right way and try to promote evidence uptake on the back end. And this learning health systems is just a natural evolution of that, but we're building the research right into the fabric of our system. Right into the fabric of our system. So right in with our decision supports, our informatics groups, our patient care services committees, our patient and family advisory committees. Research is part of the fabric. It's no longer district. So researchers have a seat at the table like any other person would be at that table. And you can kind of think about it as a bit of an R&D function of our system. Any other industry has R&D functions. Hospitals and our healthcare systems are generally not. This is a constant function to make our products better, safer, cheaper, and more focused on the consumer, which is our patients and our communities in rapid cycle. Okay, that's the idea. Another quick diagram for you is it's also a partnership. I've talked about two partnerships here. I've talked about researchers, and I've talked about our system partners, our operators, our clinicians, our managers, our directors, our vice presidents. But there's the third leg of this stool is partnerships with patients, families, and communities. And this is from a diagram from one of our patient partners who says, yeah, that's a partnership. That's the weakest leg of the stool. We are not effectively incorporating patients, families, communities right into the fabric of our planning and our science. And so she would posit, and I would agree with her, that we need to really emphasize that third leg of the stool. Do we have any patient partners here today? Okay. That might reflect that stool, okay? We're not listening to patients and families, right, even in this room. Okay? So what do I talk about defining a learning health system? I want to focus on that last part about what a health system is, because that often is not very well defined. This is my idea of what a health system is. Okay? You might have slightly different ideas, but we can talk about it. A system delivers an integrated suite of services, not a patchwork, not a fragmentation. So things are integrated. Home, specialty, primary care, hospital care, home care, long-term care, ambulatory specialty care. Right now it's fragmented all over the place. It's integrated across sites and over time, and we've done parts of that in Canada. Clearly, Vancouver Coastal has integrated community sectors now, and so forth. Okay. It relies and strengthens on primary care, prevention, ambulatory, and home care. That's where the emphasis is. And we use hospitals and long-term care, the most expensive parts of our system, only when they're needed. Not as stopgaps for everything else that's failing, which is currently often what we do in our emergency departments. Okay. Second, we organize and deliver person-centered care that's rather than just reactive, it's anticipatory. We're reaching out to people, not waiting for them to come. We're accountable for defined populations. We know who all of our population is that we serve, every single person. We know who's not coming as well as who's coming. And we are also accountable for the people who are not coming through the doors, as well as the ones who are not. If you think about other systems in the world, that's how they think. Do we think about that in Canada? Do we know at this hospital system, this hospital, who we're accountable for? Okay. Accountable, addressing medical and non-medical determinants of health, clearly beyond just health care. We now are intersecting with social care, with housing, because we know that so they're part of the health system, our housing authorities and so forth. We started with equity and Indigenous reconciliation, and that's not an afterthought, that's a forethought. That's where we start thinking about those, not where we end. Okay? And then finally, it's supported by an integrated suite of all the back office supports. Integrated IT, integrated financing, integrated people, integrated by back office functions. That's a system. Do we have systems like that in Canada? So I'm being a little bit rhetorical here, because what we're doing in learning health systems is not just improving the system, we're building it. We're building it, because we don't have this in place. Okay, you'll see all these terms in the literature, and they're all similar to the term learning health system, so don't get confused by them. And but the core concept behind all of them is you derive data from your practice in your management systems. You derive knowledge from that data with advanced research methods. We feed that knowledge directly back in time with decision supports and so forth, right back into management, into practice. And we watch what happens in the effects. We feed that information back. Okay? So it's these rapid cycle improvement cycles. Okay? Some say, well, don't we do that already? Isn't that just quality improvement, Rob? And I would say, yes, but it's more. Yes, but it's more. We build on the chassis that we've already established for decades around quality improvement, which is rapid cycle of change. But what we're now doing is really amplifying that with advanced research methods, with advanced biostatistics and artificial intelligence, with advanced ways of doing qualitative work right into the fabric of our care. Okay, another just quick concept for people to that often get confused is that learning health systems operate at different levels too. and they're complementary, or what you think of them as nested. So clearly, patients and clinicians at the bottom level. We've got to make sure that we have learning activities around day-to-day clinical care for them at the base. Okay? But that's not all. They need it nested within a system that works to promote that in terms of teams, programs, facilities, local systems, hospitals. Teams, healthcare organizations, and local systems have to be able to organize and deliver those services in a way that's productive. Staff them. And that's where I and Carrie work, is at that meso level. And then clearly we need policies, procedures, funding, all of that from regional and provincial levels, and that has to learn. We have to learn how to change how we pay, how we regulate. Those are all learning activities as well. Okay. So I'll give you that's the background. That's learning health system. Does anybody have any questions about any of that stuff?
Okay, I'm going to have to ask Sue so that you stay in fine.
Sorry. Anybody have? I have to be recorded. Yeah.
Ken,
Sorry.
did you bring the masking tape for the
Carrie's going to be out there. So, any questions on any of that? It was a really rapid fire thing, but that's the essence of what we're talking about learning health system. It really is a really advanced merging of research right into the fabric of our systems. Okay? So, now what do you do? Okay, I give you lots of terms. So, who does what, when, where is the next question. And so at Trillium, we said, okay, so how do we bring this to life? How do we incorporate? What types of research? Where do they intersect in our system? And so practical purposes, for our own purposes, bringing it to life at Trillium, we created this action framework that guides how we structure, how we organize ourselves. And it's now been published in Ontario, and many organizations are now taking this and using it for themselves, okay? Because it is a way to think through it. Saskatchewan, Newfoundland, Quebec, a whole variety of places across Canada in different places are using this type of framework. And you'll see it's oriented as an engine that's deliberate, and that's because patients and families could understand engines. They understand it. You need fuels, you needed movement, you needed brakes, and you were going somewhere with it. Where are you going? You're going to the quadruple aim metrics, but actually every one of those metrics you have to have equity centered in that. So equitable experiences, equitable outcomes, equitable staff outcomes, equitable approaches to staffing and people, and then equity in terms of affordability, not placing burdens on some groups, financial burdens on subgroups at the exclusion of others. Okay. At the center of the diagram is a whole bunch of learning gears, and I'll tell you what that specifies the research types and the evidence types. I'll just quickly go through that. At the top is all the fuels and accelerants. These are things that are the ingredients. This just doesn't naturally happen on its own. These gears don't turn on their own. They need to be primed with these types of things. Patient and family engagement apparatuses, equity deserving group apparatus to engage them, capacity for science, the right scientists that are there embedded, funding, data technology, decision supports. All of those things are necessary ingredients to make that how you function. And then there's moderators and breaks, which are things that are important. Ethics. Figuring out what priorities are. We can't learn everything. What are we going to learn? Those, we have to have mechanisms to establish those. Okay. So what are these learning gears? And this is our scientists, and we have research chairs at every one of these gears, because we all work together on these ends. First is advanced data, and it's around data analytics to understand the nature of the problems, what are the problems, who's affected, who's not affected, and so forth. And there are advanced methods particularly new predictive methods with artificial intelligence and so forth to predict who's going to need what at some point. Okay? So I won't go into it a lot, but it is really, really advanced population-based analytics. Okay? The second is advanced evidence synthesis mechanisms, because you're not the only problem solver, you're not the place solving these problems. Other places are. So how do you figure out what's happening other places so you can feed that into what's happening in your place? Understanding their context, but feeding it back. And then you bring these two sources of information together, advanced synthesis methods, advanced analytics, down now into co-design. So this is the expertise of Carrie, is around how do we take these sources of information and make it meaningful in our context, for our people dealing with our problems. And it's bringing people together with advanced user-centered design methods, advanced patient-centered, with physicians and clinicians and patients and equity-deserving groups and administrators and funders coming together to say, how are we going to solve these problems? Then you can come up with a beautiful design, but unless you implement it in a sophisticated way, it's all going to be for naught. Some people will get it, some people won't. So the fourth gear is all about implementation science. The world has exploded in implementation science in the last few years. We have a variety of implementation scientists now at our institute that can really help figure out how to make things sticky, how to convert the minds and souls of our staff, how to lead, how to make sure we provide audit and feedback to get things moving, okay? And advanced methods in this area. And then finally, rapid cycle evaluation and feedback. So this is no longer the 5-year randomized controlled trial. This is really rapid cycle feedback with hybrid methods, merging quantitative and qualitative methods so we can really find where the problems are now, not waiting for a while, so that we can adjust our strategies. Okay, so that's it. Any questions on that? So that defines what the science is. And you can see where the affinities are. So the data, our data scientists now work directly with our data people in the hospital and at our system. Our implementation scientists work directly with our project management teams. Our patient family experience, patient co-design work directly with our patient and family advisory committees and our patient experience councils. Our evaluators work with our data and analytics fund. Okay, it's merged. It's merged. Okay, so that's it. I'll give you a quick example. This is Trillium Health Partners. This is one of our design events. This is our group of leaders a few months ago, all getting together, mostly doctors, all the clinical leaders, people like you in all their teams, the managers, directors, all the clinical teams are at this meeting where we're deciding on the priorities. Where are our priorities? What are we going to do? And come to priorities. There's the CEO and there's the medical director there. And it's all based on strategy of the hospital. What is it that we need to solve? What are our biggest problems for each of our clinical programs? Cardiac, women's and children's, laboratory medicine, so forth. Okay, Trillium, I won't go over this much, but it's big like you, not as big as you are, I don't think. 10,000 employees, about I can't remember how many physicians we have. I think it's close to 2,000, and 14 different clinical programs. The only thing that we don't do is transplants and trauma. The rest of it is all there, and they're regional leads for regional big cancer programs, big cardiac programs, big heart stroke programs. All of this is in this background, and serves a population of about 2.2 million people. How many people do you serve? Okay. Yeah, BCH. How many people would be you would consider your population? Okay. So we're in the ballpark, big population. We're the only game in town. There is no other hospital. It is Trillium. We are responsible for those 2.2 million people. Okay. So we decided a few years ago to create the Institute for Better Health, and they recruited me with the sole purpose of becoming the R&D purpose for the hospital system. And so we built it over time, and you know, this is an article that came out from the University of Toronto on the workings of our institute and how we're really trying as best we can to integrate with our whole system. Okay, so my example today will be really quick, very, very quick, and then Carrie's going to take over. It's going to be an example about home hemodialysis, very simple example about what the problem is and how we solve this issue. It's to improve the uptake of home hemodialysis. Do we have any people from nephrology here? Do you run a dialysis program? I'm sure you do, right? Okay. So the problem is that that it's drastically underutilized, home hemodialysis in our system, drastically underutilized. And people are relying on hospital-based dialysis. And we know that's not right for these people. Home hemodialysis is safer, better patient experience, and it unloads capacity in the hospital for people who really need to be there, because we don't have enough dialysis beds. We don't have enough dialysis beds, and right now we're over capacity in dialysis. So how do we grow the use of home hemo so that we can preserve the hemo beds that we have in the hospital? And right now, only 4% of our patients are using home hemo, even though it's the preferred clinical option. 4%, and it's the best option. There's a problem, okay? And this shows you, there's a lovely forest plot about the effectiveness of home hemo, and it really shows that effectiveness on mortality, it's similar to transplant in terms of its effectiveness of home hemo. 4% of people using home hemo. Evidence is clear that this is what we should be doing, according to the nephrologists I know. Okay, so what's the problem? Why is it that we only have 4%? Well, that's what we started to look at. We looked at our data and tried to unpack who's getting home hemo, who's not, looking at their demographics, trying to see who's predicted to be successful and whom will not, using our internal data. But more than that, we actually used advanced qualitative methods with Carrie's team to go right in to interview patients. So we interviewed 10 patients who were never on home hemo, 10 patients who tried but failed on home hemo, and 10 patients who ended up being successful on home hemo. And then we interviewed all of the physicians, nurses, clinical educators in our home hemo, in our dialysis program, to try to understand what's going on here. Okay? And what did we find? Found a lot of surprises. First of all, patients wanted to be on home hemo. They believed the evidence I told you, but they didn't feel supported. They didn't feel they had the confidence to manage big hemodialysis machines at home that demanded water and electricity. So most of their problems were that they wanted more support. If something happened to them in the middle of the night, they had a 1-800 number. They didn't feel confident they'd be able to solve the problem with that home hemo machine in the middle of the night. Okay? They felt overwhelmed and chose not to work through the barriers because they didn't feel they got support from the hospital to do this. Okay? There was a mental barrier because they didn't want to make their home the hospital room. So how could we non-medicalize? And we didn't address that at all in the training, about how do you incorporate into your daily life. And the patients who were successful on home hemo thought that they needed some training wheels. Like, let's try it out somewhere here before I before I get this huge machine and have to purchase everything. Like, let me try it out, because then I'll see whether it works or not, and I feel confident. Those are all things that we didn't know, and all things that we could address. Okay? And the physicians and nurses said similar things. Actually, they didn't even offer home hemo to many people because they didn't feel that they could succeed. They thought, oh, they're not capable of doing this, so we're not even going to go there. They were concerned when patients had multiple health concerns, expressed lack of hesitation, were not motivated, and had uncertainty to try home hemo. Okay? And we had no strategies from the physician's point of view of addressing their hesitation and building their motivation. None. Okay? And so what did we do? We redesigned the home hemo program, where now we actually had much different training with patient support workers. We didn't hire anybody new. We just trained, did something different about what they were doing. Redesigned the training program, make it more longitudinal, created a place where people could come in and test home hemo before they were done. The patients that were previously failed, we went back to. Said, okay, it didn't happen the first time. Let's try again. Okay? And now working with our nurses, physicians, educators to understand how we have to develop more self-management support for patients with hemo at home. So just a real example of real redesign of our home hemo program with a learning health system. So now we have a new program. It's being implemented as we speak. It's not going to be right. We're not going to have it done correctly. We need to evaluate it, and we need to readjust it. Okay? But we can already see the successes around this. We're seeing much more use of home hemodialysis with this very simple change. And now we're seeing more capacity in our hospital with outstretched for our hospital hemo beds. So there's an example. I think I'm going to hand it over to Carrie. A very simple example, but it kind of tells you the type of things that we do now at the Research Institute.
I might take this off. How's everyone doing? I tend to go off script, so just roll with me. We have about 15 minutes, I think. So who attended the conference yesterday? Hands up. Okay. It was an awesome conference, by the way, so hats off to those who organized. I talked about collective impact. So, meaning we can do so much together, more than we can do on our own. And so put your hand up if you're currently facing a health system problem that keeps you up at night. Okay, pretty obvious, right? Put your hand up if you think you can solve this problem on your own. Exactly. There's certain things, so we call them technical problems, that have technical solutions, that they're tried and true, there's best practices, we know how to solve them. But there's other things that we refer to as adaptive challenges, where multiple partners have to come together, including patients, families, providers, leaders, to really understand how to solve it. So who would like to share, instead of using the example that we have, who would like to share a problem that they're currently facing in their day-to-day practice? Anyone? Anybody? Who's feeling brave? Who has the courage? Who's feeling brave today?
We could, do you want to get Yasmin's slide up? Is Yasmin here? Do you want to speak to that, Yasmin?
And then we're going to work through the framework. So you're sort of on the hook with this example, and then we're going to walk through what it looks like when you operationalize the problem that you're facing through the Learning Health System framework. Thanks. Okay.
Good, I got my coffee.
There you go. So we're rolling with it.
Somehow I knew I'd stand up and get my coffee this. Okay.
Okay.
Yeah, just
Run
a
that.
quick, frame of the problem would be great. Thank you.
Okay. So the problem we have right now is really related to long-term care, which is a systems problem, because we know that, at one point we used to look at long-term care, and it was, one of our resources, one of our tools in the community belt, right? However, now we know that really it is only the sickest folks that are going into long-term care. Often I hear people now talk about long-term care as being our ICU in the community, right? And so it's becoming a challenge, and we know that when we start having wait lists for long-term care, that then impacts the rest of the system. So it impacts home support workers going into people's homes, because you're looking after people who are sicker. We're putting in more hours of care, so we require more home support hours, more people, which we don't have. And then that then backs up into acute care, because then we have more people, ALC, sitting in hospital waiting to get into long-term care. And then, the other impact on families is that, families, this really leads to increased caregiver distress, whether individuals are coming into hospital or whether you're looking after someone at home. So what we know is right now, if we look at the next 5 years, so 2024 to 2029, our projected gap really for long-term care beds is going to be over 2,000. So we'll have a gap of 2,000 long-term care beds, which is significant. We also know that we can't build our way out of this, because building any long-term care facility will take 5 years, 3, maybe we're good and we do it in 3 years, right? But we can't build our way out of it, and the cost of every new long-term care bed is pretty significant. So we have this issue. We know that our modeling takes into account that there's private long-term care that people have options for. It takes into account, the fact that people are staying shorter time in long-term care, the death rate, all of that's factored in. So we're pretty comfortable with the modeling. We know that we've got the increased number of clients waiting each period, and as per the model predicted, currently over 600 clients waiting on the wait list, average of 4 months. What we now, I just looked at the data yesterday, that we have individuals in hospital who are emergency placements. We also have people who we support up in community as emergency placements so they don't end up in hospital. But what happens now is those community placements that we used to place within 24 days are now waiting 54 days. So that's significant of trying to prop them up. And we know that ALC is going up in hospital, and I think Michelle could probably attest to that as well, right? So this is our challenge. So I'll stop there to see, hopefully that's helpful.
Thank you so much, Yasmin. That's a really, really good overview. So what she did is she painted the problem, right? And she showed that she has data to understand the population. That's the very first step in a learning health system, is the analytics and population insights is what's the problem, who are the people. So do we know, what's missing in terms of what we understand about the population? I'm just going to cruise over here. We're making this interactive now.
To be honest, I'm not sure that there's anything missing about the population. I think as we begin to understand our wait list better, what we're finding is that family members, so our wait list is long. And I think what happens, family members, and I'm not sure if people appreciate the analogy, but you know how you know that the wait list is going to be long, so you wait list earlier. So kind of like when people have children and they know they can't get into daycare, so they wait list earlier, right? So we're seeing that when we start looking at the wait list that's 5 years long, when we start going through it, if someone's been on there for 3 years and still has been okay, then we probably know there's some things we can do about the wait list. The other piece we recognize is that some people on the wait list are really, really sick. They have dementia, and they're physically robust, but a lot to look after. So the caregivers are so distressed looking after them. But long-term care is built for people who are physically compromised, who require lifts, who require these challenges, versus the population of concern is dementia. So there's just a mismatch there. I hope that answers your question.
Yeah, thank you so much. And I'm so glad you also talked about family caregivers and what they need, because they're absolutely essential. What I find is when we look at the sources of data that we have, for sure it helps, but there's other ways to reach populations that might not be represented in the data. So there might be particular communities that are feeling left behind, equity deserving groups, for example, people that don't necessarily maybe feel comfortable using the healthcare system. So there's ways to go out into the community and do qualitative focus groups, interviews, to better understand the needs of all the population. Because again, some will be represented in the data, some may not be in the data. So that's another strategy in that first phase of a learning health system, to really understand who your population is. So I will roll through. So, and this captures what we talked about. So the first part of the learning health system, understanding the population, is looking at what data sources you have, what data sources you don't have, who's represented in the data, who's not represented in the data, and perhaps doing interviews. And if you reach into the community, are you going to the community to extract information? That's often what we do. Or are you going into the community to build relationships and to understand what really matters to that community? You might uncover that some of the reasons why they don't want to go into or stay at home are maybe different than what we had assumed in the first place. So it's really good to spend time in the community to understand, how do they define the problem? What information can they share so we can better understand what their needs are? And then in the second part, you don't necessarily, if you're building an intervention to, say, help people age at home longer, you don't necessarily have to start from scratch. And so hands up if you've done some sort of like evidence synthesis, literature review. Yeah, exactly. And so there's ways to look at what have they done maybe in other hospitals in our community, what have they done across the province, maybe in other contexts, just to get a sense of what's out there. But again, you might not see anything that's completely perfectly fit for purpose within your local organization where you're doing the implementation. But you might have something to start with. So you might do a little bit of what I call like co-redesign. So you might be starting with a program that's been tried and true and worked elsewhere, but you're going to pull in members of your community. It could be people that are on the wait list currently. It could be their family members. It could be providers that provide those services, organizational leaders, people that have the power to implement the intervention. That's really important to have. To put your heads together to say, what could we reasonably do, maybe in our hospital or in our community, to support people. So in this case, in the community, if we're looking at a home care intervention. So the mistake that I've made in research is I've had really strong partnerships with clients, caregivers, providers. But what I didn't do, when we did our co-design, we tried to reach as many people across Ontario as possible. Different hospitals, different providers, different patients and families, but we didn't have a receptor for the work that we were doing. So had we started smaller, local, maybe one hospital, one unit, starting from the very beginning to understand what does it take to actually implement the thing that we want to implement, because it's really, obviously it's really hard to do, and then you can scale it out after. So sometimes if you go too big, it's not necessarily going to work. Start local, be intentional, make sure all the partners are there that have the power to do the implementation work. And then in the implementation part, thinking about where exactly are you going to implement this? Who is involved in the co-design? Because maybe those people could reach the program, but people that weren't involved, maybe they're going to be left behind. And then you could perpetuate existing inequities if people that are impacted by the problem don't have access to what you're doing. And also with the evaluation, asking yourself what metrics, and this is asked probably when you're doing the earlier planning part of your work, is what are you going to measure? And what matters to patients and families and caregivers, what matters to providers, what matters to leaders, so you can actually evaluate something that's really, really meaningful for the people that you're working with. There we go. So any questions about how to operationalize Learning Health System? Did it land? Is it stuff that you're doing already? Did it feel like, how would we actually do this? Or did it feel like, okay, I think this is actually possible? Thoughts? Yeah. So now you get the mic.
Hi, thank you so much for that great presentation. My name is Van Dad. I'm a physician and currently involved with Vancouver Community as interim SMD. So I have a question about sort of the difference between LHS and QI, because I've been going to QI sort of conferences for 16 years now. I think organizations over the past 2 decades have invested a lot of money into developing QI teams and QI departments. So are you kind of suggesting that maybe it's time to evolve those teams into LHS teams by adding more rigor into the analysis, by adding more scientific approaches or scientists into the teams? Is that really what we're talking about here, practically?
In essence, yes. It is evolving the quality improvement infrastructures. I mean, we'll still always need traditional quality improvement infrastructures, but when we have big thorny problems, often like we were talking about just one of them, quality improvement, traditional metrics, traditional methods are really not up to the task to do this. And so we really do have to advance the methods that we're using and using more sophisticated research methods. So it really is taking account for these big thorny problems, like this one we've talked about, like the hemodialysis one that we talked about. It's really trying to now maximize the power of the scientific rigor that we bring to that and the new sciences that we can learn. So the way we think about it at Trillium is really just, it's not that you sit over here as a quality improvement department and we sit over here as a research department. We now talk about merged infrastructures. We work together. We don't work independently.
And I think if you're, wondering if you're not already doing this, how to start doing that. If you have, is there a lot of embedded scientists at this hospital? Do you have trainees from the universities and colleges that come in as learners? Yeah. Because there's opportunities to build capacity by plugging people in where it makes sense. So for example, with my portfolio focusing on patient experience and engagement, Rob mentioned I spend a lot of time with the quality and safety team and supporting them with, how do we best measure patient experience? I know you're focused on that. How to, use what we learn from patients to improve how we deliver services to them. But I think what a lot of researchers fear is that when they're in an embedded organization that you're going to get plugged in like everywhere and expect to be all things to all people. And that's where researchers will probably put their hands up. People in the hospital system, operators will say, well, no, like we're not really doing anything useful together because everyone's scattered trying to do everything. So if you're really intentional, whether it's a trainee, a learner, a scientist, plugging them in where it makes sense, where they're excited because they're going to see the impact of their work. And then the hospital operators, be it providers and leaders, have that scientific expertise, and like magic can happen from that. I know it sounds very idealistic, but it's about that matchmaking piece where everyone wins and everyone can see the impact of the work. And that's a very kind of short-term thing that you could do by partnering more deeply with UBC. I see Sterling here, finding trainees and people that can come in, and then you can have a cycle of innovators that are in this space, moving forward quality improvement projects, but really more robust, which makes it a learning health system.
And I can tell you the new trainees that we work with, and Carrie and I both teach at the University of Toronto, with many, many health services, health systems type of trainees, health informaticians, with really deep knowledge and deep methods expertise. They're hungry for these opportunities, because many really want to see their work have impact. So they're wanting to find places to partner in systems and bring their expertise with these real advanced methods to bear. And some of them are so smart, I can't keep up with them. These are the type of people we need to bring in. Sorry, what was the question?
So here in BC, we've got doctors by law, non-medical trainees are not allowed.
Yeah, I don't think I've run into that particular challenge in Ontario, but what we bring in is our teams to work with, the clinical teams. So they're not often intersecting directly with patients, but we're intersecting with the operators. For instance, we just recently have an organizational scientist that's coming in that really has deep knowledge around how to organize and bring business analytics to bear. He is working with many of our teams that are in the enabling functions. So he's not touching patients per se, but he is absolutely working and producing good science with the leaders in the system. And I think that's probably allowable in British Columbia.
So I'm director of innovation at UBC, and I come from a research background. Our world's like, we have some biases there. And I'm just listening to your description of
Yep.
and the research in particular. And I am wondering, is that a capacity that can, we have the framework about asking, a good question, being able to think about how to gather data. Is that something that can lead that hybrid power, and can be used through an organization to, like, every person involved, or is that something that is held just by trainees and the university, the current researchers?
Yeah, I think there's different strategies. Yeah. So what I'm hearing you say is, how do we bring in that expertise? Do we grow it internally in our people, or do we have to bring it in from university academics and from, or hybrid or something? And it's probably both those things. There's often a real people function in our organizations. They want development opportunities. They want to learn new things. They want to become advanced. So we have that type of person that we try to grow with our scholarship programs and so forth. And we work with the universities to bring them in and get them the additional training they need to do those functions. So that's one type. And then we do bring in researchers from academics, and they maybe often aren't even in our hospital. They are located at the university entirely, but they want to work in our environment, and we have the rules around how we operate here. And it's not about you, it's about us. Let's move ahead on this. And then we have our internal group. We believe that we have to have some internal expertise. So Carrie was entirely an important hire for us because she brings incredible expertise in patient and family-centered co-design. We couldn't do it without her. So there are some real strategic hires that we had to make to bring that back. Coming from the innovation point, that's another word I didn't use today, but it's a really important word. Okay? And the Research Institute, you saw it's called the Institute for Better Health. It's about research and innovation. They're two sides of the same coin. We're talking about innovation things here. And so it really is studying innovations, bringing innovative thinking into bear, trying new ways to do things. And so we're really thinking about how you merge the ideas of research and innovation in the same platform. That helps. Yes.
First of all, hi everyone. I feel like I had a party and I brought all my friends here, so it's nice to see everybody. Yeah, you got absolutely. I've got a job for you if you like. But I guess I've been reflecting a lot lately, and I guess I've got a couple specific questions because I think we have all the constituent people in the room. Like, that's what's great with the organization we've got. I see informatics, I see patient experience here, I see operations, foundation is here, quality. So I think we've got all the pieces. Some, I think, maybe not proportional to the size of the cogs, but I think the pieces are there. And when I see what you have done, I see you as sort of integrated and bringing these pieces together around problems, I think, and using all those pieces together. And so you're almost like the glue, and then setting the organizational and the organization sets the priorities. So a functional question, how do you pay for that? Like, how do you pay for you and your team? Because that's always very important in operational type funding. So that's my first question for you.
Boy, you give me the hard questions. That is a bit of a real challenge, is how do we finance this and how do we pay for it? And it's a bit of a hybrid approach. And you're absolutely right. Often I play that brokering role, and I'm the matchmaker. I bring teams together. But before I talk about financing, it comes back to strategy of the hospital. And our strategy as a mission-driven organization, we have that strategic plan. That drives what we all do. We don't have a different strategy at the Research and Innovation Group than the hospital strategy does. Informatics doesn't have a different strategy than they do. Our clinical departments don't. So we use the strategy to guide what we do together. The priorities come from the strategy, the strategic discussions, and then we all come together to solve those problems. Strategy is really important. And I couldn't emphasize how important it is to live your strategic plan, to figure out what are the problems that we're solving that articulate from that strategic plan, and then use that strategic plan to bring your whole organization together to solve the problems, okay? Because I don't have to convince my informatics people that this is a good problem to solve, because the organization has already done that. Okay? That makes sense? So that's the first part.
So as the foundations here, I think. Yes. So philanthropy plays, yeah. You're doing it all. Wow. Philanthropy plays a huge role. And we found a donor that got behind the idea of a learning health system, but also they really wanted to see change in the system. So we funded, through Rob's Vision, accelerator grants, which brings together, and it's very similar to what you're doing at the Research Institute and at SPORE, where you incent patient partners to come together with clinicians and researchers to pick a wicked problem that they want to focus on, and with small funding, they start to work on something together. So through that, you get different partners working together, so you start to build and change the culture that way, but they start to solve real-world challenges that they're facing, and they can actually start to see in the examples that were shared over the conference, they can see changes happen, and that gets fed back to the donor, who then wants to keep reinvesting in that vision. So it's a very kind of concrete example, but getting people behind the vision of what's possible in a learning health system, simply by saying, like, we don't want the status quo anymore. We need to fund partnership work. We need to do things differently, and we can actually see small changes become scalable over time. And that's really attractive for a donor that is probably maybe using the system, maybe as a burnt-out caregiver, and they want to see changes in the system. So that's been a big enabler.
I can't tell you how important our partnership has been with our foundation, and I'm so happy that the foundation is here, because, you know, this is not something the hospital can always afford, because we are supposed to be delivering care and not supposed to be producing research. Governments and CIHR, this is not terribly sexy funding for them. They really often want to do discovery-related research. The foundation, although they do more and more fund this, there is a priority at the federal government to do more and more funding in this area, and we've been terrifically successful in getting in with CIHR. But the foundation has been important for the seed money, for the early starts, the early wins, that bringing our donors together in our community. But what I've learned over time working with our incredible foundation is that we don't sell it as research. We sell it as change. Okay? It's not about producing research. It's about changing care in our community and making our community better. That's what it's about. And that donors can get behind. Absolutely. And if you can show them that there's a partnership with researchers and the system to do that, they're willing to invest in that. And they're willing to invest actually even in bricks and mortar if you're going to change what you do in those bricks and mortar. So it's been a bit of a winning strategy. You have to work, you have to understand the donors, you have to understand what their interest is, their concerns are. You have to have conversations with them in the right way, sophisticated people, but it's been really an important strategy for us.
I think we're close. Yeah, of course. Yeah, of course.
Yeah, no problem. So I'm Angela Chapman with the foundation. Not the foundation, I'm with the foundation. No, not here with my checkbook today. But we work very closely with Rachel and Darcia. We've had some success with the grants around VCH, BI, Boehringer Ingelheim being our partner in that. And that is just one of many. That's just an interesting kind of new approach to this whole field. Many of the research centers that we fund, whether it's Vancouver Prostate Center, Care, they have embedded scientists, and they're very much in that translational research space and translating that. And so we have that experience of telling our donors, look what happened because of this. And it definitely is inspiring. What we're observing is the gap for Vancouver Coastal Health, and I've been engaged in conversations with a number of people here on this, is that we're doing a lot of sort of one-off pilots and seeing incredible information coming back that says, wow, like this really makes a difference. Just a very sort of banal, very low cost example of that would have been the iPad translator system, for example. So stuff like that. And then it's not rolled out like further. It's not, it maybe not go to another hospital in Vancouver Coastal Health, not across Vancouver Coastal Health. Some of it has been successfully rolled out, lung screening program, for example, cancer lung screening program across BC Cancer, taken on by the government. But that gap there in terms of like scaling and going to other health authorities, crossing that terrible health authority border in British Columbia, that's where the frustration for donors comes. That's where we're at now.
That's such a good point.
That is just such an important comment, because donors are willing to put up the upfront costs, but they're expecting you to do something with it and change what you're doing. So you actually have to figure out a path forward to make it sustainable and to actually incorporate the stuff that you've done into normal business operations at the end of the day. And that may mean that you actually have to advocate and change funding formulas with the government of BC. I spend way too much time of my time at Ontario Health and the Ministry of Health and Long-Term Care at the provincial level around evolving regulations, funding, and that sort of thing to support the innovations that have been coming out of Trillium, because that's what's going to make this sustainable. That top end of the learning health system, the regulations and funding formula, they're stagnated in many respects. And so you're absolutely right, and you have to think about that ahead of time. You can't do it. And most donors now are sophisticated. They're not going to give you money unless you show how it's going to be sustained in the long term.
We're coming up against coffee. Are there any other questions? Because I've got, perfect. I want to get you. As I'm thinking about that, I wonder about the incentivizations between scientists at the university and how do we embed that science into the health authority? Because I think the incentives are sometimes different here. But Amanda, you're a pretty important role in this. Thank you.
All right. Amanda Chisholm from the Research Institute. Just to kind of add on to Angela's comment, and Carrie, you mentioned the presentation the other night by Dr. Cindy Lau in transplant. And so that is funded by our foundation, and we have annual, internal award programs for research every year. But there is the gap when it comes to, they do, their project over, a 2-year term, and then what happens after that if to sustain the funding for that change. So in Cindy's project, looking at pharmacogenetics and making sure that we're dosing patients with the right level based on their their genetic makeup, eventually that has to be sustained beyond a project grant, right? And so I think that's the gap. So we have a lot of those like fuels and accelerators that you have in your diagram embedded into our programs, but they're funded over like a 2-year grant. And then it is supported by the foundation, yeah.
Thank you. That's great.
The core person of our team, and increasingly core, is our government relations people. So our government relations people at the hospital that are our advocacy arm for new changing funding, new changing regulations. Now we actually forecast and we actually work with them directly early on to figure out what is the solution and what do we advocate for, not because that cycle takes a long time. How can we change what we need to change early on? So they are a crucial part of how you operate.
I think we could not stop all day if we wanted to. So why don't we break for a quick coffee and be back for sort of 10 o'clock, and I'd encourage you to come speak to Rob and Carrie and take advantage. Sarah's here in the room as well, and so take advantage of our people here. And thank you very much. Okay, if anyone can take their seats, please. Okay. So we're going to get started again. Great, thank you. So I'm going to briefly introduce, so the next part of this is that I think we've, and I truly believe this, I think we've got some really good pockets of this important work being done in the organization. And our goal here was to highlight 2 projects that span both community and acute care. And while I want to also sort of celebrate the accomplishments, I also want us to identify what are the gaps, right? And where we are, so whether it be patient co-creation, whatever that is. So start thinking about what the gaps are while we sort of celebrate the work that's being done. So I'm going to introduce, I don't think unfortunately Andy is here today, but we actually have a senior learning health systems lead at VCH, so we're very fortunate for that. So you're a leader, you're on the coal face of this, Christina. So thank you. And then a very good friend of mine, Maya Sagedi, who's a transplant hepatic, pancreatico, something surgeon. So she does, if I ever had a liver problem, first person I would phone is Maya. So anyway, come up please, Christina. Thank you for doing this, and I'll get your slides up. And the best thing I think is just you can hold it, or you could just stand here if you want. Do you want the clicker?
Yes, please.
Do you want to see this? Would that be helpful?
Let me see this. Is it bothersome if I look around like
No,
this?
I think as long as you're in front of the microphone.
Yes, I will just go a little bit back and forth.
Yeah, we can move the microphone too.
Yeah.
Yeah, so if you just talk like that, you're certainly welcome to do that. Or you could just sit down if you wanted to too, if you'd rather do that. What would you like to do? Because I can do this here.
Apologies, I have bad vision, so it requires a little bit of logistics to figure out what works.
Because the other thing you could do is
I think this works better for
okay,
me.
why don't you do
Yes.
that, and if you do want to sit down, and I'll
Yes.
bring the microphone to you.
Thank you
Does
so
that work
much.
best for you?
That
Okay.
works great. So, wonderful.
It's
Oops.
not going to work. So because it's loose.
Okay.
How's that? Why don't you try that?
Can you hear me well?
Is that working?
Does this
Everyone
work?
in the back?
Okay, great.
Okay.
All right.
Thanks.
Thank you so much, and thank you for the opportunity to share with you our early experiences with one of the micro-level initiatives, as we discussed. And this is with Vancouver Community Health Services, where my role as senior learning health systems lead resides. And so this program was established just 2 years ago in 2022. And to our knowledge, this is the first learning health system specific role and program at the British Columbia Health Authority. And so the broad program aims for us is to foster the LHS culture, and to demonstrate value to our organizations, which is today is a great opportunity, hopefully, at least to stimulate interest. And so we are pursuing these aims through various activities, which include engagement events to raise awareness of learning health systems. We're also building some learning communities and embedded research initiatives as well. And so today I'm going to speak about an embedded research initiative. And so what is embedded research? It's a key activity in learning health systems, and it is a way to implement and to generate and implement evidence and knowledge to improve practice. And so researchers involved in embedded research initiatives work together with healthcare staff and leaders. And the key is that they work together on problems that are priorities for the health system. So the researchers bring the expertise, the health system brings the questions and the problems. And these kind of teams, we know from the literature, are very often hybrid academic health system partnerships. And this brings many benefits, but it also brings the challenge of operationalizing and resourcing these kind of arrangements for the long term. So we heard about all of this today. So how do we move beyond the pilot? How do we make this really last and stick and become a resource for the health system. And another thing that we know from the literature, as well as our early experience, is that co-creation of the research at all stages from the very beginning is absolutely essential, and also strengthening the integration between research, the quality improvement infrastructure, and operations. And so, although Andy couldn't be with us today, I would like to credit him with some really great ideas and thoughts about this presentation. And so the way he expressed it is that the value for operations in embedded research is in its ability to support continuous quality improvement through the ongoing generation and implementation of evidence. And learning health systems, as we heard today already, provides us with the framework and the tools, and I consider embedded research as one of the tools that can help the health system improve care and health outcomes. And so this is the rationale and the motivation for establishing the embedded research pilot program at Vancouver Community. So our pilot is an 18-month pilot funded by the Ministry of Health through funds that were provided to Simon Fraser University. And so the funds support 2 embedded faculty members from the Department of Mathematics who together supervise 3 integrated SFU VCH research teams. And there is 1 project in 3 participating programs at VCH. So one is Vancouver Community, where also my role is based, and also the Regional Public Health Program, as well as the Indigenous Health Research Unit at the VCH Research Institute. So this partnership actually builds on a very long partnership between SFU and VCH that started in 2013 and has focused on operations research. Our overall goal for this pilot is to build a case for embedded research within VCH. So we will be evaluating this in collaboration with Dawn and Penny's team at the Center for Clinical Epidemiology and Evaluation. And part of the deliverables is a sustainability plan that we are going to work on with an expert advisory committee. And so this program has launched just recently in September, and the program goals are to build sustainable research capacity, to provide training and mentorship to students, and also really to create these frameworks for ongoing embedded research. And so one question that we often get with how do we pick the projects, because this is a unique opportunity for us, but it's also a very limited resource right now. So, and especially Vancouver Community that has over a dozen programs, it was a challenge to decide, so how do we equitably decide which projects to work on? So we decided to develop a process that really aims to minimize competitiveness. So it was all, again, about collaboration, being iterative, and working with the team. So we informed the teams about this opportunity, and then the embedded scholars worked with the directors in consultations one-on-one, and they in a back and forth process figured out which of the ideas are appropriate for this opportunity. And so operations research, I should say, is a discipline. It's generally a branch of mathematics, sometimes engineering, and it's focused on improving business processes, including healthcare operations. So an ideal problem is one that does have a clearly defined operational question, and it's also one where the levers of change can be clearly defined. And also data, perfect data, we never have perfect data, and also for these kind of projects, it's not necessarily to have perfect data, but we do need some data to be productive. So based on those criteria and the back and forth iterative consultative process, we were able to identify 3 projects. And this was also helpful because we did not have to reject anybody. So the researchers were already worked embedded and provided consulting, advice, and even alternate funding opportunities for any ideas that came up. And so these are the 3 projects. The public health team is focusing on identifying individuals experiencing homelessness in the VCH administrative data, and this cohort will be used to plan for service planning in the future and also to support surveillance. And the Indigenous Health Research Team is working on the Indigenous Primary Care Network, and that project is focusing on addressing capacity management questions. And Vancouver Community is working with the housing program, and the question there is how do we evaluate an allocation algorithm of the patients seeking housing in the program, mental health and substance use housing specifically, and how do we optimize the algorithm and allocation to various models of housing. And so these projects, as I mentioned, they are just starting. So we are hopeful that by the end of the year, we're going to have the early results. What I can say is that there is really enthusiastic participation. In fact, in our recruitment, we had VCH staff and leaders volunteering to be a part of this. So that's wonderful, but results are yet to come. However, as we were preparing for this embedded research initiative, we had the opportunity to work with the Vancouver Community Primary Care team already since January, and this was a way that we could kind of pilot test our embedded research approach. And so I can tell you a little bit about a project that is almost at its completion now. So the researchers in the primary care team worked to find optimal panel size for care providers within community health centers. And at these centers, the client population typically has complex care needs. And so the usual average panel size does not necessarily apply in that case. And so the researchers and the primary care team worked together to develop a simulation model of the appointment booking processes at the community health centers that included both booked and walk-in appointments. And they used this model to determine optimal panel sizes depending on various conditions, such as client population characteristics, and also the definitions of key performance indicators. One example of that is time to next available appointment. And so through this, they are actually developing lookup tables for the various clinics and various parameters that can really be a practical tool for primary care teams. And also, this was a way for us to develop an integrated embedded research model. So how do researchers with their very different incentives and focus and knowledge work together in an effective way with our healthcare teams? And so we already had some really valuable lessons from this experience that we're already able to implement in the pilot projects. And so in closing, just a few reflections of what we have learned so far from this experience. The absolute importance of building authentic relationships is really key, and actually not only gaining but also keeping the trust of all partners from all sides is active work every single day. And also, these collaboration skills that we need for a co-creation culture, they're not necessarily always intuitive and readily available. It is something that we have to learn together by trial and error, and we have to keep working at it. And the long-term sustainability is an important issue. So we're working on that with various partners. And finally, that there are really great opportunities in this endeavor for everyone involved. So, for example, the researchers have great opportunities, trainees have great opportunities for impact-oriented careers, for the health care partners, there are opportunities for new resources, and that's just the beginning. There are many. It's hard work, but the rewards are great as well. And collective impact from your talk really resonated with me because this is our growing list of partners and research team members, and it's definitely a joint effort, and it's extremely rewarding and can't be done alone. So thank you so much.
So we're going to do both talks together, but I saw, will you have your hand up, Rob? You sort of get privilege here if you want to point of privilege, or do you want to wait till after?
Why don't we wait till
Okay. No, you and Carrie, you guys can do whatever you want. Like, you guys are the guests here, so. Okay, Maya, I was going to bring up your slides. Do you want to, how do you want to do this? Do you want to stand and just have the mic up?
I can sit down too.
What's up to you? Whatever you like.
It's,
What would you prefer?
I'll sit down.
Okay, perfect. Okay, so. I was put in touch with the technical aspects, but I should have my 12-year-old son to come and run it because you do a better job.
Thank you.
Man, so we'll use that, whatever you want.
Okay, sounds good. Thank you very much. So nice to be here. Thank you for the opportunity to present our work at Vancouver General Hospital. I know many of you, and many of you have actually been a part of a lot of these initiatives. So this is an acknowledgement that the land on which we gather is a traditional and unceded territory of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations. So I have no disclosures relevant to this presentation, other than the fact that I see the world through the lens of a surgeon. And today, really, the purpose was to talk about the evolution of our liver transplant and liver cancer surgery IPU over time, and how it's better served the clinical practice and our patients. So I'll talk about the context of the liver transplant program and liver cancer surgery at VGH. I will introduce our IPU, and I will talk about how the IPU has helped us and has been integrated in some of the patient quality initiatives over the years, and then I'll touch on challenges and future directions. So Vancouver General Hospital is the sole provincial referral center for patients who need liver transplant. We have since 2010 performed nearly 1,000 liver transplants. And based on a report that was that analyzed patient referrals between 2011 and 2022, we had a total of 3,040 patient referrals. Out of those, 1,134 patients were placed on the wait list, on the liver transplant list, and 905 received a liver transplant. You can see the map of the patients that we had transplanted. And the ongoing challenges that we face are lack of, especially in the beginning before the IPU was initiated, was a lack of outcome measures. We didn't know how we were doing in terms of complications. And also we were always aware of the fact that we had not enough time to see and evaluate patients in the suitable time period. So this is actually our IPU dashboard. IPU dashboard was started in 2017, or the IPU liver transplant was started in 2017. So this is a snapshot of all the patients who were transplanted and captured since its inception. And you can see that we had transplanted 635 patients. The distribution is skewed towards people who are older, in their 60s. More male patients transplanted than female patients, and this is just a snapshot of what we had captured through the IPU.
So currently, this is not the only IPU. There is across 3 divisions, including general surgery, gynecologic oncology, and neurosurgery, a total of 16 IPUs. The ones that I am involved with are the hepatic oncology, so it's the liver cancer IPU and then liver transplant IPU. Stephanie Chartier-Plante, my colleague in the picture, had taken over the liver transplant IPU after Stephen Chung and I started it with Ariana Cruz, Morad Hamid in 2017, and many, many more people. So IPU is really a learning health system, has it at its core because it does capture all of the components important to outcomes. First of all, it captures patient demographics and details, age, location, sex to start with. It does look at outcomes, and those ones can be analyzed by age, location, gender. It can also look at costing data. It utilizes process maps of the patient journey. It looks at objectives and key results, which are dynamic and can be changed over time depending on the priorities in that patient population. And it also looks at some core measures, which are really relevant to surgery. And what's really at its core are these patient populations, which we aim for them to be quite homogeneous. So what we do is really valid for those patients rather than spread over very, very, very different patient subpopulations. This is a snapshot of the leaders, the IPU leaders across different IPUs at Vancouver General, so trauma and ACS, HPB and abdominal surgery. Some of these IPUs are actually just starting. So for example, pancreatic transplant IPU is very, very new. And that's responding to the fact that we've revived that program. Oncology, and then there's of course labs and committees that support the whole IPU, led by Dr. Heather Stewart and Dr. Jason Park. So this is looking at the value-based healthcare and the fact that we want to look at a patient-centered approach that's organized around a condition and taking care of a patient from the time they're referred to us to after they receive the treatment. Really, liver transplant IPU is very, very suitable. Liver transplant unit was very suitable for this because we did have a unified patient population. We had a multidisciplinary team from the inception consisting of physicians, allied health, nurses, addiction specialists. And then we also had a pre-set up team that was taking care of the patients after the transplant. So it was really an ideal setup for IPU. And some of the people are in the picture here on the left, and Dr. Chartier-Plante and Peter Kim on the right, recent transplant, very stylized photo. We're using new filters. This is the liver transplant process map. So very, very complicated and really broken down in the IPU into different pre-assessment, assessment, treatment, and survivorship components. But that's really at the core of the IPU. If we simplify the patient journey along the liver transplant path, patients are referred to us by their primary healthcare provider or a subspecialist taking care of them. And then they're seen in the liver transplant clinic by a variety of physicians, allied health, and undergo many, many tests. Decision to place them on the list is made in a very multidisciplinary setting. And then once they receive the transplant, they have a really close follow-up and really long-term follow-up of complications, recurrence of their disease, and many other aspects of their health. So this is a snapshot of the OKRs that are part of our IPU. And they have really changed over time, but this was one snapshot of the OKRs where we were looking at, we were really focused on how long our patients were ventilated after a liver transplant. And we wanted to really select the patients who could be vented or extubated earlier to shorten their time in the ICU. And then at that time, we were really focused on our complications and need for reintervention. So our patients being reoperated on a lot. Why is that happening? And we wanted to know if the liver grafts were lost and at what frequency and whether that could be prevented. This was the core measure that's at the crux of, I think, most of the IPUs that looks at sepsis, different infectious complications, pulmonary emboli, as well as length of stay and mortality. So that's always present with every IPU. And then different IPUs are at different stages of incorporating patient-led measures. We have incorporated it through the early patient experience team effort, which was quite incredible, and we're still working from this. This was in 2021, where about 10 patients were recruited of different backgrounds, locations, genders, etiologies for liver transplant, and then they were interviewed by the patient experience team. And this is just one of the snapshots. This is the one that I used for my QI initiative project. But essentially, patients were saying that pre-transplant was a time of anxiety and stressors on them, and not knowing when things would happen or what would happen was really a source of stress, and therefore managing expectations around timelines was a big aspect of what would improve and alleviate their stress. This were some of the values of short and long-term goals that patients expressed in these interviews. Travel, staying healthy, going back to work, having the sense of freedom, and many other learning points came out of that. But just to bring it back to then what was done by the surgeons over that was supported by the IPU. So for example, Dr. Chartier-Plante was really focused on that extubation and time in the ICU. And as a part of the quality, physician-led quality improvement project, her and Dr. Kitson were able to create an initiative where patients would be extubated early if they met certain low-risk criteria, and that significantly shortened their ICU stay and hospital length of stay. And this is now incorporated in our IPU, so this is one of our OKRs. So it's really helped us sustain that important initiative that was identified and pioneered by two physicians. And then, rather than focusing on that post-operative, perioperative outcomes, where we focused again was to shift the quality improvement focus on the pre-patient experience based on the interviews with patients. And this is where I was involved as a transplant surgeon and a cancer surgeon. I wanted to focus on a group of patients that needed liver transplant for end-stage liver cancer, because wait times in that population are very stressful. Not only do they have liver disease, but they also have a progressive cancer which cannot always be treated. So we, as a group, decided to do a simple thing, which is simply review all the referrals before the patients are seen, in order to eliminate the patients early who don't meet our criteria, to reorder any outdated or missing tests, and then recommend a plan of action. And we did there's no p-values here, this was not statistically significant, but we did make an impact on wait times, as you can see on the run chart. So, and this was now incorporated into our liver transplant IPU, and it is one of the OKRs, where you can clearly see that the wait times from referral to patient activation are shorter. And then this is possible no OKRs. We're always thinking about how we can improve patient care, and it's kind of an evolving idea generator. Do we want to look at referrals? Do we want to look at how long it takes us to look at a referral and then see the patient in clinic? Do we want to look at how many no-shows we have? Are we wasting any tests, or are tests expired? Do we need to align the time from when the patient is seen and when their tests are done? Because if you see them too late and their tests have expired, then you're just basically wasting resources. So many other things that are constantly evolving, and this is really the crux of what IPU has enabled us to do, where we can conquer kind of new challenges and change our focus under a unified umbrella. This is courtesy of Dr. Adal Shahal. He is one of our transplant hepatologists. He's now building on those two challenges, and he's looking at all the patients who are referred, so not just the cancer patients, to see how we can improve our wait times and patient experience. So IPU has really supported us through different initiatives and has helped us change focus from one to the other patient population. We've really been fortunate to have this, and we've been fortunate to have the energy and from everybody who has participated, not just the physicians. So, what are some opportunities for improvement? Highlight critical learning and collaboration between surgical colleagues. So, the way I think of this is, I'm an IPU lead, and we quarterly review our outcomes. But what I could do better is really engage my colleagues more on a regular basis to incorporate the OKR results into our daily practice and conversations at all times. I think it would be great to refresh our patient experience and patient feedback. It's been 3 years, and it was so much work in the beginning, and it's given us so much energy, but it's been 3 years. So it'd be great to get more information from our patients and really make them a part of the ongoing OKRs. I think overall, this has illustrated how physician quality improvement has really been hand in hand with IPU, and how they've been really incorporated just organically. And that's enabled, I think, the physicians to keep that energy and keep improving things and keep that sustained through the IPU model. So these are different families of mine. I wanted to show the 5 surgeons on the helipad, Vancouver General Hospital, and then the previous picture of our liver transplant team. Not everybody's there; it's a huge team. And also, I wanted to thank everybody for being a part of this journey. Not everybody's listed, but yeah, thank you.
That was great. Thank Christina. Fantastic. Thanks, Maya. We only have Rob for 10 more minutes because he's called to yet another talk. So maybe we'll use that opportunity. Fortunately, Carrie's decided to stay with us till 11, so thank you, Carrie. But maybe I want to open it up for discussion in the room, but maybe just if you have some comments first or thoughts.
This is just delightful. Your learning health system is alive and well at Vancouver Coastal. Just 2 terrific examples of what you're already doing, and you may not even call it the learning health system, but it is embedding all the thinking that I've talked about today. Maybe I can speak a little bit about the first presentation. And thank you, Christine. Where's Christina? Oh, Christine. I just want to come give you a hug as the first embedded scientist at the institution. Just terrific. It must be a bit lonely. So, we're with you, but that is indeed the essence of what we've built at Trillium, is your role. We just happen to have 30 or 40 people like you. working as embedded scientists in different ways, in different programs and so forth. But exactly the type of stuff. Your priorities are set by the institution, you're solving problems, it's around partnerships, you're producing good science, you're working in relationships, you're bringing patients in, and you're doing these iterative change cycles. So it is good, it's the institution's priorities, not your priorities. Just a couple of thoughts on Christina is I think it's really important that the relationship with SFU, okay? And often embedded scientists have to have an academic home as well to foster their science and understanding, develop a scientific community, and so forth. So that relationship with SFU or with any of the other local universities that you have, UBC, is really important. And at Trillium, we make, because it's so important, we actually have now developed a strategic alliance with the Institute for Health Policy Management and Evaluation at the Dalalana School of Public Health that really is around sharing this mission around establishing a learning health system at Trillium. And that has been vitally important to produce a vital academic home for our scientists, a pathway for students, a pathway for funding, a pathway for influence, and so forth. So I just really wanted you to think about the relationships you have with your universities and how productive it is in a relationship. Often our universities, we have at hospital systems relationships with faculties of medicine and faculties of nursing and that sort of thing. But often the scientists that learning health system science are not in those faculties. They're in the business school. They're in the informatics department, they're in engineering, they're in the public health schools. So how is the interface with your university partners around those parts? So that was my only comment, but just terrific. And the only thing that made me sad was it's called a pilot program. Okay? Figure out how to keep you and grow and establish it more than the pilot program. And then sing your successes across the organization and show how you can do this at every part. The last presentation, just before I go, also just a terrific example, because that's really showing how you're doing rapid cycle and you're really changing care for people. You really have changed care for people. Those liver transplant patients, their care is changing. That's what it's about. And you're bringing that whole team together. I'm not sure how that was all put together, but boy, that's a lovely example as well. And it is now just bringing more power of science into that, and extending it and making it better, bringing more patient experience in it. Looking at the equity journal for different people. So there's that can continue to be extended in multiple ways. So just congratulations.
Okay, just before you go, Rob, I know you're going to, any thoughts on from what you've seen today before you leave? One or two opportunities for us as an organization, if you had to say, this is the one or two things that we want to do moving forward, what's the next step for us as an organization?
I think it's making choices and having a bit more deliberate around where the strategy is. If really the organization wants to go in this direction, then it really needs to put some might into it and strategic direction around how to do it and establish actually some form of formality around here. Right now, it appears that it's in its natural growth, which is fine, but at some point you want to amplify that with some real strategy in the organization.
Great. Thank you. Thanks for joining us today. Actually, just a quick round for Rob. Thanks very much. And thanks for staying, Carrie. That's great. So I'm going to open up the floor now. I've got some questions, but first, any comments that anyone, other questions for our presenters or any general comments? Boris. So Boris is a scientist at C2E2.
Do I need a microphone?
Yes, of course you do, my friend.
Oh, because you want to record me. Thank you very much, Christina, for your presentation. And I was thinking about, thank you, for one of the resource that you may consider. So I'm a professor at UBC, and through duty rotation, I became a program director for Masters in Health Sciences program at the School of Population Public Health. And our students mostly residents at hospital or different hospitals actually, and or medical students and kind of. And I've noticed that over the kind of past 5 years, their projects they embedded already, so they are part of the some clinical divisions and programs, and their questions more and more are not on the clinical side of the story, on the healthcare delivery side. So if you're interested, I can link you with my manager, and certainly would actually be very helpful. Thank you.
Thanks, Boris. Thank you for that. Any other general comments before I start picking on people in the audience? Vandad, thank you.
I always have that's why you got invited.
Thank you. So first I want to thank Christina and Maya for your presentations. Excellent work. I'm familiar with both of your works, but maybe a little bit more with Christina. And I think it kind of dovetails to the comment that Rob mentioned, which is being intentional about this stuff. I know, having worked with Christina, that it took a lot of bottom-up approach, a lot of, sweat equity into making it work and building those relationships. But as an organization, we really, we talk a lot about this stuff, but I don't see a structure that's going to support this going forward. And that's going to be a huge risk for all of these pilot projects. So I hope that at some point there's a venue where, as an organization, we can talk about this, because if it wasn't for Christina's determination, a lot of that would not have actually happened within VC. Even though there's a lot of people who are supportive of the idea and want to be part of it, we don't seem to really we have all the pieces, but they're not connected,
So let me follow up with you
On that, what are we missing? So you've heard this, you've heard what an LHS looks like and what they do with Trillium. You've seen all the wonderful pieces parts that we have here. They're all the pieces, patient experience. What is that piece that we're missing? Because it's like, we're not going to invest in a wholesale 30 scientists for leads and that. That's not sustained. That's not a reason. We have to show value. So what's the next step?
I think the first step is really a structure that brings people together in a systematic way. I think that's the first step. I do think that at some point, addressing the resource issues is going to be important. You cannot have one person or two trying to do this across our healthcare system, which is massive. Vancouver community itself is a huge organization unto its own, right? So I think the resource piece is important, but I think the first step really is to actually just have a venue and a structure that will actually facilitate the existing components to actually meet and talk and strategize.
Okay, I want other comments. I just want you to think about, is it new resources, maybe, or is it existing resources and prioritization? So any other comments, Rachel, I think?
Thanks. Darcy is not here, so I'm a little nervous about speaking up, but she could, let's just give her a veto. But I think the other thing that's missing, but it's coming, is focus, in getting really clear and very vocal and visible about our strategic priorities. And we do have a strategic plan. We do have priority populations. We are getting close to understanding the change that we want to see. And I think that work is rolling out, but I think that's the other key piece, right, is focus.
As an organization.
Yeah.
I want to open up again, but first, is there a question with that? Oh, perfect. Can I come to you, because I'm right here, and you're next, but I want to pick on Liz, who's our head of patient experience, because it's like, what I thought is that it's the biggest cog, and we're the smallest team for patient experience. It seemed like the biggest disconnect. But anyway, your lens, and I'm going to come over to you next, Corinne.
Thank you for having us here, Don. I appreciate it. I am so inspired by everything that Trillium is doing. I had a great conversation with Carrie, and we're new. Our patient experience program is 2 years new formally. We were able to start with some of the IPU work as an evolving team. And that notion of mindfulness around truly being people-centered, how we're engaging with patients and care partners in co-design with a view to moving that into co-production is so important. And to your point, as a teeny tiny team working on projects here and there, we often, Joyce and I, think about how do we grow this? And so to your question, how do we actually I love this idea of how we move it forward. And I liked your point, Carrie, about, not starting too big. We're a huge health region, but maybe we start to integrate a practice like this in smaller projects or something that we're starting little by little, but really thinking about the opportunities to bring in that scientist research LHS lens. I think that could be the glue and the change to truly move the dial on the experience work and everything for our organization towards improvement.
So let me just, before I go to Corinne, what does that look like? Does that look like do we poach Carrie and bring her here? Like, yes. But what is that piece that we need? Because I agree, we're going to have to start small and build out. But what is that one piece? If I come to you and say, okay, we're committed, what's that one piece you need to do your work?
You always ask the hard questions. I love it. But no, my answer to that is relationships. I understand that how we fund and structure those relationships is a question for people far above my pay grade. But like Andreas and I were speaking earlier, there's opportunity in our relationships and our connections to academic organizations, to the Research Institute. I think for me personally, as one little program, how do we start to think about this in addition to the bigger decision makers is how do we build relationships that might not immediately require funding, but can be key partners. And so that's what I would like to think about.
Well, we're lucky we've got some of the decision makers in the room. But first, Corinne. Corinne's a head of Emerge and also a scientist at C2E2. So
thanks. I'm also academic lead for the emergency department health improvement network across the province, which is perhaps my favorite role. I think there's something else that we can do and that we should do. I think we need to harness our clinicians much better. There are clinicians all across the, wherever you work across the province that have fantastic ideas. We've had a lot of issues with burnout and wellness, and we've emphasized what I'm going to call the dive out. Well, there's also the dive in. And during the pandemic, we started trying to think about how do you systematically reduce barriers to participation in research. And so we created a data set that was harmonized across the province for a specific condition, and we used an open science approach to actually allow clinicians who had never participated in the process of science before. And we had people come out of the woodwork from, Abbotsford Regional Hospital. And we currently are pivoting this network, and we already have 22 emergency departments in British Columbia and 63 across the country, across 9 provinces that are really interested in this. And it creates the space for folks who don't want to have an entire academic career, but are really interested in innovation. They're interested in diving in. They have a pet peeve around a specific problem, and they can then come bring this idea in a collaborative, non-competitive approach where they get then linked to somebody who has a lot of statistical expertise with a data set that may already be cleaned and verified. The data and membership agreements are signed. Hopefully that is already funded. That's what we're currently after. But this creates a completely new framework for engaging physicians, and they feel really positive about it. And it's a way for them to express the current frustration with the current system and contribute in a very positive way to health system redesign.
Yeah, I think I know Penny's always spoken about the model where we have like a competitive process for great ideas, and then we bring it to the scientists and the ops and all that to how to actually enable those ideas. Yeah. No, I totally agree. I think clinicians are very engaged, but there's barriers in terms of mentorship, release time, how do you fund that, stuff like that. Great, thanks, Corinne. Any other comments? I'm going to pick on a couple people here in a second. Barriers we have. I was going to pick on you, Michael, so thank you. You were next. Yeah, thank you. You saw me looking at you, right? Yeah. Thanks, Mike.
Hello, everyone. It's great to see so many familiar faces here. It's really exciting, as Liz said, to come together to chat about this. I completely agree with what you're saying, Corinne. In the practice of doing meaningful innovation and improvement, there are so many siloed barriers in the system. And just reflecting on what Rob said as well, that's really what he was saying. Like, it's very difficult to do things off the side of our desks, or maybe we start something more informal. At some point, we need to look at what Trillium is doing around their institute, and that's all angles, including the fundraising, including amplifying funding sources from donation, innovation grants. Rachel, I'm looking at you. I know we've worked together on a lot of those, but also operating funding, because so much of it from a sustainability perspective needs that. Co-leading the embedded research initiative that Christina has been so wonderfully helping with, and really the force behind. There are so many things that come up from a detailed standpoint, and execution being everything. Even things like across SFU and VCH, we don't have one OneDrive. We have to sort that out, right? So if we have governance cascading down to enable these things, it starts to remove the barriers that prevent integration and seamless work. I can see at the front line the teams want to do it, but then we're filling out 15 forms in order to enable that. And I see you nodding, Corinne, because we've worked on stuff together too, and it's just like goes through so many gates, right? So part of the power of what Trillium, I think, really has done is that they've created this institute that they have scientists working more seamlessly. And I'm not saying, Don, that we go and hire 30 scientists, because that would be very difficult for a whole number of reasons. But we don't really enable that seamless interaction, even if we say we want it. There are so many barriers when you get down to the brass tacks of actually doing it. And so where we see fantastic work, and it's so great to see all this work because I've been part of a lot of it in different ways. Every time it's a fight when it comes down to the micro details of getting it through. And it's not because of resistance from above or anything like that. It's literally all of the different steps that teams have to take in order to work together. And then we all get dragged back to our sort of core responsibilities. So I think what Rob said is entirely true, that we need to look at what our bold step is with the future of our research institute, what we need that to be, how that brings us together, because we have an opportunity now to look at that. And we can't just keep doing things because of the goodwill that we all have.
I want to follow up on that. I'm going to put you on the spot because you know data more than anyone. What I heard from Rob a little bit in some of the other groups is like a prioritization. Does decision, what are you guys calling yourselves now? Analytics and support? Data analytics and support. Do you have the resources is it a priority problem? Are you pulled in so many different directions? Could you reallocate around standardized priorities of the health authority? What are your thoughts for that?
I think just in general in this province, we're not Ontario. And I'm also adjunct at U of T in the same faculty as Rob. So I see through Vector Institute, what is Vector Institute is doing in AI and other things like this, and the amount of funding. The university's goal in 10 years is to fundraise $3 billion. And they probably will achieve that. So I think we have to be realistic about what resourcing we have. There's all the budget conversation, et cetera, but at the end of the day, there's only so many of us here, just 4.5 million in this province, and we need to be able to prioritize that. We're trying to shift towards doing more value-based care with what we do with our data work, and we're doing that in collaboration with like yourself and other physicians that are now involved. But at the end of the day, it gets very hard when it's not clear what the overall priorities are for the improvement and where we should spend time or where we shouldn't, because it's very easy to get sucked into just mandated reporting always. Now, the other piece really is, and this is a much longer conversation, I'm sure some of you are interested in, we don't really measure the right data necessarily. And we're starting to get it with Cerner, but where the implementation rubber hits the road, we don't really have that data. And this is me supporting Liz in a way, because the sort of prems is one thing, but then there's also the wider understanding qualitatively of how we do co-creative design and how we involve patients in that. That is really data. And then, so when we're going to do our implementation design, if it's a new technology, a new medical device, a new whatnot, we'll have our vendors help with that, but then we don't have what Rob is mentioning around design and implementation science. We're measuring things for design and implementation, not for business case approval and higher level system function.
That's great. So I'm hearing priorities, integration with the university, or synergy with the university, and co-creation with patients. Okay, any other comments? Oh, great, here's.
Hi everyone, I'm Sarah Gilsher. I'm an associate professor at the University of Toronto. I also was an embedded scientist with Health Quality Ontario before the government sort of restructured how Health Quality Ontario is and became Ontario Health. So I would like to build on what Michael was just saying in terms of, I think one of the strengths, at least in what I've been observing in my time here in BC, is there is a lot of opportunity, I think, for collaboration, which I think is more tricky at the University of Toronto. So we might have more money, but it's trickier for us to know who's doing what because we're so big. So I do think that we know that care coordination is better in rural environments because people know each other, and we talked about the relationships, and Carrie keeps talking about the collective impact, which is so important. So I do think that's a strength here, and I completely echo that. I think at some point, I think, it's, do you put your money in a savings account or do you put it in the stocks, right, in terms of what kind of return on investment you're going to get? And I think if you invested strategically in a core group of scientists, mixed methods, implementation, co-design, people who can understand big data, admin data, qualitative data, et cetera, you partner with universities, so the university's also on the hook financially. And I think that's how Trillium has really leveraged the Dahlana School of Public Health, for instance, because there's less risk that way. And you get return on investment. So for instance, as part of my embedded role with Health Quality Ontario, we got some operational funding through CIHR. Carrie was part of that. So that allowed us to have operational funds, a couple $100,000, to really leverage the work that we could be doing for system performance. So, and I know Carrie's been leveraging a lot of funding that way as well. So those are just some high-level ideas there.
So what I've heard is we can poach you as well, so that sounds great. I think, Sterling, you had a comment, and then probably what we'll do, we'll bring a session to the close, but then we still have the room if people wanted to stay and ask questions or something like that.
Great, thanks very much. So I'm Sterling Bryan. I'm a senior scientist at C2E2 and prof at UBC. And I think I'm just really inspired by what I've heard, actually. And I've learned a lot about what's happening in Trillium, but I've also heard a lot about what's happening at VCH that I wasn't necessarily as aware of as I perhaps should have been. So I think we've got many of the key components in place. And I think it goes to this point about how do we bring it together? And I think we've got the components in place. We've got teams that are actually doing this work. And doing it in a really impactful way, but not connected. So how do we build that community of practice, or a community that wants to keep coming together so that we can fill the gaps that are there? And I think part of it is about having these great examples shared and making sure that we've got a way of communicating these examples. But I'm also conscious that we need not just bottom up, but we need top down. So how do we get this message and these stories onto the radar of leadership within the organization? Because I think if we don't get that, then we're going to struggle. So I think we need to foster the community, but we also need to find a way of communicating to senior leadership about this as well.
Couldn't agree more. Unfortunately, we have senior leadership here that wants the last comments. I'm going to get Margaret, and then I'm just going to ask Carrie to speak, and then we'll close the session. So thanks, Margaret. Here you go.
I never in my wildest dreams thought I'd be talking as a top-down person. But I am a family doc. I'm with C2E2, but I'm also on the board of Vancouver Coastal Health. And one of the things I think it's important to know is that Rob came to an expanded board meeting about now maybe 6 weeks ago. And so this was all the board members, the board chair, the CEO, senior staff, all the medical directors of care from the COCs, in addition to other regional leaders. And he gave his similar talk to today. And people were very enthusiastic. So I think that there is a kind of a chemistry of interest on the part of the top-down crowd. And unfortunately, some of the key players, so Patty Daly, Vivian Eliopoulos, Penny Ballum, were unable to be here today because they're out of country, visiting, etc. But there is a scheduled meeting, Zoom meeting with Rob coming up in a couple of weeks. So I think that those are very positive things. We also have this moment where there's just been an election. I would say there's probably some soul searching on the part of the Ministry of Health about what to do next, right? Because we know a lot of money has been plowed into healthcare, and results, meh. It depends how you look at them, but definitely I think a learning health systems approach that embeds patient design, patient experience, that calls on us to slow things up, not down, but slow things to build relationships and get it right, I think will be quite appealing as a sort of a process to sell on the part of the ministry. And then there's this huge social capital that people have mentioned today, that it's so much fun to be part of a team that tries to change things and can see at least partial results and continue on.
Thank you, Margaret. And I would like to encourage everyone, there's this Learning Health System interest group, which was kind of Margaret's idea to begin with. And so some of us who know each other and knew a little bit what was going on got together. We're very small. We will have a survey go out after this meeting, and I hope you'll comment about it, and I hope you'll join the Learning Health System interest group, and we can grow and grow. So thank you, Margaret. And my challenge to Margaret, and I have said this to her before, is that I want her to discuss with the Minister of Health the mandate letter. I want it to be a negotiation, not a one-way street. So thank you, everyone. We're going to let Carrie have the last word, but I want to say thank you, Pam, who's hiding. And did so much of the organization.
Great, thank you so much, and so wonderful to be here today and learn all together, and my ideas are growing. This is really bi-directional. We have a lot of work to do at Trillium still, and we have strength and opportunities at U of T, and Sarah, I'm glad what you mentioned. Sometimes we feel so big, it's harder to build those relationships, and when I walked in the room today, wow, there is a buzz. Everyone was excited to be together, everyone's excited to share, and the easiest low-hanging fruit that you can continue to do is this. Sharing spaces, sharing ideas, because that builds momentum, and it gives you time for sense making. Because if not, we're busy, we have our to-do list, we have our checklist, we don't have the time to stop and think and connect. And this will build so much momentum in years to come. Christina, I'm thinking you started to build momentum in 2013. And now you have a whole pipeline of trainees, and you're changing the culture and how care is going to be delivered and how people want to work in the system. So I wanted to specifically call that out as an area of action as well, is to keep providing opportunities for learners. They are looking for spaces to learn. They're hungry for these opportunities. They have the mix of skills that Sarah mentioned, the mixed methods, the quantitative, the qualitative, the community engagement skills. So continue to build on that. And also one thing we didn't talk about today is what can we stop doing? What is performative and actually ridiculous that we're doing for the sake of doing, and it's wasting our time? And removing that can create the space to do more innovative, exciting work. And I know that's a bit of a pipe dream, but let's really have a serious conversation about that and create the space to do the work that we really want to do. So thank you so much.
Thanks, Carrie. Okay. Thank you. Okay, so with that, I'm going to bring the session to close. I really thank you. I totally agree. There was an energy and really good representation from everybody. So what we'll do, we'll thank you. If you want to leave. There's coffee in the back. I think there's a whole thing of treats outside. So grab treats on the way out. And if you want to stay and chat, then that's okay. That's great. We'll welcome that. So